Access Minnesota. Issues that matter to you. Access Minnesota brings you the newsmakers and the stories that shape our everyday lives, with analysis from University of Minnesota faculty experts. Now, here's Jim Dubois.
The Ebola outbreak in West Africa last year sparked an international response as foreign healthcare workers set up clinics in the affected areas and worked with local authorities to contain the disease. This month on Access Minnesota, we talk with one of these aid workers, University of Minnesota Associate Professor of Nursing, Cheryl Robertson. Robertson traveled to Liberia in West Africa this past November to help fight Ebola and launch a treatment center. We'll hear about her experiences in the midst of this devastating virus and how the efforts of healthcare workers have now stabilized the outbreak. We'll also learn why Robertson believes the media overstated the dangers Americans faced when Ebola patients were treated in this country. Cheryl Robertson is an associate professor in the School of Nursing at the University of Minnesota. She traveled to Liberia this past November to assist in the international Ebola response efforts and to help launch an Ebola treatment center. Professor Robertson, welcome to Access Minnesota.
Thank you.
What prompted you to travel to Liberia to set up the center?
Well, I've been working in global health for, my goodness, the last 30 years. So obviously what was happening in Liberia, Sierra Leone, Guinea was on the radar, and on my radar, and I just felt this sort of a background voice that just kept saying, you know, Cheryl, geez, you know, you're a public health nurse, you're Catholic, it's like, my goodness, you have no choice but to head over there. My colleague Dorcas Kunkel, also in the School of Nursing, who was actually raised in Liberia and is very involved with nursing education in Liberia now. We basically went to the School of Nursing and went to the American Refugee Committee and got a lot of support from the school and the university to forge a partnership between the school and American Refugee Committee. And it was actually a lovely thing in many ways, because we were hearing that universities across the country were being very clear that their faculty or students, it makes sense with students, but their faculty, they would not in any way support faculty to go and assist in the Ebola response for all of the reasons that one can imagine. And University of Minnesota basically stepped up to the plate in a very careful, methodical way, don't get me wrong, and in a Minnesota way said, no, this is what we do. And it was just so cool to be part of that. And the relationship was forged and off we went with a team, you know.
How concerned were you personally about going into an area with a deadly, contagious disease?
As the plane was about to land in Monrovia, everybody on the plane was going there for one purpose and one purpose only, because you wouldn't fly to Liberia for vacation, and they were going there to respond to Ebola. So when the plane took off from Brussels, lots of bravado and laughter and talking and, oh, I've done this and I've done that, and people showing their street cred, you know, well, if you worked in South Sudan, if you worked in Somalia, and it's like, yeah. Then as the plane is going in, the plane is very quiet. And there is this awareness that all of us are thinking, oh yeah, this is it. Now, this is where the rubber meets the road. And filing off the plane, getting out on the tarmac and walking in, it was a pretty silent crowd. And so, was I frightened? No, but you're certainly very, very aware. And you know, we would joke in that sort of black humor kind of way, but where things would come into your, you know, you'd climb into bed at night and think like, oh, I wonder if like I have Ebola on my socks. I wonder if my, you know, if I get, you know, I mean, so sort of irrational thoughts can come into your mind. But when you're, you know, but basically day to day, no, I don't think that I felt fear, and I don't think that my colleagues did either. But you certainly felt careful
The outbreak killed over 10,000 people in Liberia, but recently the country's last Ebola patient was discharged from the hospital. Tell us about your time in the country. Did it seem to you when you left that the worst was over and things were improving?
Absolutely, absolutely. For example, our first day, my colleague Dr. Kunkel and I we were just, when we first arrived, she's very familiar with Monrovia, so we took a walk, and we're walking by the National Hospital, JFK Hospital. And just like in the New York Times pictures and CNN footage, there are people outside the gates and who appeared to be waiting for care, very, very sick. One person appeared to be dead, and it was like, oh my goodness, this is what it looks like. By the time we left, there were reports that all of the Ebola treatment units had empty beds. So that's how quickly the things started turning around. And due to the efforts of thousands of people out there in the fields doing, following cases, doing case tracing, and basically most of the work that really turned it around was folks out in those villages, out in those neighborhoods, really tracking everybody who had been exposed to Ebola. And there was managing that is just more comprehensive than you can even imagine. And people are out there doing it. They did it.
When the Ebola patients were being treated in Liberia, did their survival depend upon at which stage of the disease you were able to intervene?
It's a good question. I'll give that a rather simplistic answer, but certainly the earlier you come in to be treated, the more likely you are to survive. And that changed over time, where in the early days of the epidemic, people were terrified. And when Ebola treatment units were first being built, people were terrified to come to them because it looked from the outside as though you go into those places and died, which in many cases was true, because the sicker you are, the harder it is to begin to recover. And recovery in the most simplistic way is all about rehydration. Pretty simple. And if you come in and you're able to walk into the unit and are able to hold a bottle of oral rehydration solution or water and drink it, the chances of your recovery are pretty high, or certainly higher. And you can lose, in the height of the illness, a person can lose up to 7 liters of fluid per day. That's a lot. And to be able to replace that takes a lot of fluid. And if you can drink as much as you are losing, it certainly improves your chances of being able to survive before organ damage is done, before some of the sort of horrible sequelae of the illness set in. And so as people became more comfortable coming into an Ebola treatment unit and came in on their own 2 legs walking in, you would see people that would really have a pretty good chance of survival.
When Access Minnesota returns, more on University of Minnesota School of Nursing professor Cheryl Robertson's time in Liberia and her efforts to help stem the Ebola crisis.
Access Minnesota will return after these messages. You're watching Access Minnesota. Here's Jim Dubois.
Now, back to our discussion with University of Minnesota School of Nursing professor Cheryl Robertson about her experiences in Liberia during the Ebola crisis. Tell us about the international response to the Ebola crisis in West Africa. How would you characterize it? Was it well organized? In the end, apparently effective, but was it chaotic? And what could have been done better?
If something like this happens again, and it will. There will be another outbreak. I am quite confident that we'll never see anything that looks like what we just went through, because the world will respond in a much more effective, efficient, timely way. Basically, everybody was doing something they had never done before. I mean, we would turn to each other and say, like, I've never done anything like this before. And the inevitable response was like, nobody's ever done anything like this before. Nobody, because this hasn't happened before. And Ebola has certainly happened. And most of my work is actually based in Democratic Republic of Congo. And that's where I've been working off and on for the last several years. And people say that at any one time in the Congo, there's usually at least one small outbreak of Ebola happening, but it happens in extremely remote areas and burns itself out quickly, as viruses are wont to do. And it doesn't end up affecting the larger population. That said, I'm sure that Ebola will be back in an urban area again, but we will never, the response will never look like what happened. At the same time, there's much to be proud of in the response, in terms of when there, I worked with people from Cuba, from China, from Asia, from Africa, from lots of other folks from other countries in Africa, lending their expertise, from the US, from Central South America, Europe, of course. I mean, in other words, this was a genuine global response.
Well, bringing in caregivers from seemingly almost every corner of the world,
Yep.
How much of an issue was communication among the caregivers?
It wasn't like people were just not operating in a coordinated way. It's just that it was so huge, and it took a while to organize things. I think it's important to remember, one thing I would want to say is that something like this event does not happen in a vacuum. Liberia, Sierra Leone, Guinea are countries that have just been devastated by conflict over many years, decades in some cases. And as a result of that is you've got healthcare systems and civil society in general that's just decimated. And I mean, genuinely decimated. And all of the war violence is really, really hard. It's hard on people, but it's hard on institutions, it's hard on civil society. It affects communities' capacity to be able to protect and serve. And in many ways, walking into an Ebola crisis felt like walking into a war zone, a very different type of war zone, but where you've got shuttered businesses, terrified communities, poor behavior in terms of fear and blaming others, and as a result, you've got forced migration, not as a result of conflict, but as a result of fear or shunning. And without the institutions in place to begin to address this. So, and then on top of that, then you've got this enormous global response, people coming in to do good and there's no sort of framework to support them, to set up communication systems, to house them, to, all of that.
When the infrastructure itself in those countries is not up to the challenge, how do you fix that long term? Is it going to be a situation where the rest of the world has to keep coming in whenever there's an outbreak, or is there a point when we can make those countries more self-sufficient with regard to their medical services?
Well, now we're talking about things that I think about all the time. So prior to this Ebola outbreak, I can say I never thought about Ebola. But I think a lot about healthcare system development and revitalization of civil society, revitalization of community capacity, community healing post-trauma, post-conflict. These are about as complex problems as there are. Will we be able to rebuild these systems? Well, we can't. These systems have to be built from within, but obviously a lot of support is needed. And it's about as complex as it gets in terms of the barriers. And we could talk on another show, we could talk for a long time about, development post-conflict, development in fragile states, development in failed states, and the struggles to make that happen. Most of the world is getting healthier. I mean, you look at health indicators and life expectancy, infant mortality rates, maternal mortality rates, education, literacy, you really can see a steady, boom, boom, boom. The indicators are going in the right direction. The world is a healthier, wealthier place. But of course, there's chunks of the world where that is not the case, and that's what that's where I'm interested in.
While international help was greatly needed in West Africa, much of the fight against Ebola came from the Liberians themselves. When Access Minnesota returns, Cheryl Robertson describes Liberia's response to Ebola.
Access Minnesota will return after these messages. You're watching Access Minnesota. Here's Jim Dubois.
Now, here's more of our conversation with Cheryl Robertson, who joined colleagues with the American Refugee Committee to establish an Ebola treatment center in Liberia.
The international aid efforts were certainly heroic. People like yourself put themselves at risk. Do we give enough credit, though, to the Africans themselves? Because they certainly were at great risk, and they did understandably the best with the limited resources that they had.
I'm really glad that you asked that, because no, I mean, the global response was heroic and messy and all of that we've said. But basically, this epidemic was addressed by Africans themselves. And Africans themselves that were protecting themselves and their families by putting plastic bags on their hands and tying them with rope instead of gloves. People who were basically risking their lives and very often dying to take care of their family, and in many cases not their family. I mean, we talk a lot about the deaths and the deaths of healthcare providers. It's really important to remember that the vast majority of those deaths were nurses. Nurses who rose to the occasion knowing that it was a suicide mission and took care of people. The folks who were, there was, before ETUs were set up, there were all of these efforts in rural communities to develop places for isolated care, so that you weren't caring for your loved one, your family member, there in a one-room house where the children and everybody are running around. So in other words, trying to provide like some isolation rooms nothing, but areas. And the people that were doing that kind of work were doing it at tremendous risk to their lives, and many died. And so the down and dirty work in the mud that it takes to get your arms around an epidemic like this was done almost solely by Liberians, Sierra Leoneans. Liberia was just plastered with billboards, signs, posters, health messages. I've never seen such a health message intensive set of circumstances ever. And I mean, in the early days of the HIV crisis in East Africa, you saw this entire flood of health education billboards and the like. And this was like that on steroids. Every building you walked into had a bucket with bleach water that you had to wash your hands in, a guy sitting there with a thermometer to take your temperature. So when I was in the southeastern part of the country where the Ebola treatment unit was being built in River G County, you could be in the most remote villages where you were just footpaths to get to them, and there would be a stand with a bleach bucket with bleach water in it to wash your hands before you went into that compound. And so the same people who were out there, thousands of Liberians out there fanning across the rural communities, doing contact tracing and health education, these were the people that were addressing face to face the fears, the myths, the beliefs that the West was spreading Ebola and these kinds of things.
Did this most recent experience in Liberia change you in any way?
You know, I work in really hard parts of the world, and Liberia was a hard part of the world. And I have come to see behavior in people that doesn't look good. And I'm getting better at stepping back and saying, oh yes, this is what it looks like. This is what it looks like when countries have suffered so much trauma. It doesn't make people, we have this idea that suffering somehow makes people noble. Well, sometimes, mostly suffering is not good for people, and it makes them, and many people behave poorly, and many people develop attitudes and the like that are very, very hard to understand if you haven't had that experience. And what happened in Liberia was one part of that story, is that the vast majority of people were getting up in the morning and doing the stuff that they needed to do. Kids weren't in school, so you were taking care of your kids. Businesses were shuttered, so you were, selling your wares on the street. People were doing what needed to be done to get by. And the effect that that has on me is just this, continual, just sort of admiration and re-realization that we are a very hardy species. We are quite tough, and when the worst is happening, we still take care of our kids and nurture our wives and husbands and help our mamas and do the stuff of life. And also, did Liberia change me? It added to that mix. And seeing that degree of suffering is sobering. I had 21 days of, when you saw me talk in Florida, I just come off 21 days of quarantine. So I was in Liberia, the extreme intensity of that experience. And then I came home and I was in quarantine. So the things that I normally do to make myself feel better after coming back from a really hard place is just, when I come home, my first night, I always have a welcome home supper with my son. I go to Seward Co-op and buy my groovy organic fruits and vegetables. I get on my bike and tool around. Just the stuff that sort of reintegrates me back home. And I couldn't do that this time, which was weird and disorienting and uncomfortable. And so I was left with the thoughts in my head that I normally are able to sort of wash out. That was humbling.
What would you like our viewers to know about Ebola and treating Ebola patients? Something that perhaps you think they may not understand, may fear unnecessarily. How can you enlighten us?
A crisis like what we saw in West Africa is a crisis born of extraordinary poverty, dysfunction, post-conflict collapse, a collapsed healthcare system, a collapsed infrastructure. This is not, which is a horror show for folks living in those countries. That is not an American experience. I mean, that is not an American reality. A country with a functioning healthcare system, you certainly can have people come here and get Ebola. I mean, it could happen, and it will happen again. But we have the systems in place to deal with that. And so it's very, very bad luck for the poor person that got Ebola. But for the rest of the population, it's a non-event. And that doesn't mean that we should not be careful at our borders, that we should not, if you're coming from a country that has Ebola, that it's appropriate to screen a person, all of these things. I mean, you use basic public health measures. But basically, a functioning public health care system and curative health care system would prevent nothing like what happened there could happen here.
Cheryl Robertson is an associate professor in the School of Nursing at the University of Minnesota. Professor Robertson, thanks so much for joining us on Access Minnesota.
Thanks for the opportunity. It was great.
This May marks the 50th anniversary of the most devastating tornadoes to ever hit the Twin Cities area. Next month, a look back at the night of May 6, 1965, and how the lessons learned during that tornado outbreak might save lives today. That's all for this month's edition of Access Minnesota. We'll see you again next month. Thanks for watching.
Access Minnesota. Issues that matter to you. Join us again next week as we bring you the newsmakers and stories that shape our everyday lives. Access Minnesota is produced by the Minnesota Broadcasters Association in cooperation with the University of Minnesota's College of Liberal Arts.